of this heart failure masterclass. Over the last few weeks, we have learned a lot from our teachers, and discuss various complex cases. So this is another one, and we hope to learn a little bit more about some new problems and their solutions. Over to you, Dr. Hari Krishna.
Thank you, Dr. Chopra. We will have the sixth episode of this Masterclass 2025. So we will have first a talk by Dr. Tiny Nair on beta blockers in heart failure. This will be followed by the case presentation from KM Hospital, Mumbai. And the student panel will be from AIMS Jodhpur. They presented the case last time. And the honorable faculty are Dr. R.J. Manyuran, Dr. Sudev Kumar, Dr. Surendra Diora, and Dr. Ajay Mahajan. So we have an excellent faculty, and we hope that you will enjoy the session. So we'll first go to the talk by Dr. Tiny on beta blockers in heart failure with preserved ejection fraction. Over to Dr. Tiny.
Good afternoon. Today we would be talking about basically the discovery of Sir James Black, and that is, we all know, it is James Black who discovered beta blockers. And we will be talking about a very niche area of beta blockers in HFpEF. We know that beta blockers are one of the basic foundations in the treatment of HFrEF. But we will be talking today about beta blockers in HFpEF. First, let us look at the emerging signs of HFpEF. Years back in 1986, there was a Kishimoto's group from Japan was trying to see how a T cell in the green shirt talks to a B cell in the yellow shirt. And he found out that it is a chemical called interleukin-6. Over the years, we knew that it is not just something that talks between T cells and B cells, but it has a huge amount of effect on the biological systems in the human body. For the purpose of cardiology, we know that interleukin-6 plays an important part in increased risk of atherosclerotic events by creating a milieu of inflammation, progression, and a poorer outcome of aortic stenosis, and of course, acceleration of heart failure, the topic that we are discussing today. Now, we know that when we look at a trial data from what is called a PREVENT trial, which looked into the association of interleukin-6 with heart failure in a large community of 85,000 patients. Now, when they looked into new onset heart failure in 213 patients, those with HFrEF, the graph that you see is HFrEF. See that there is progressive increase of interleukin-6 with progression of heart failure. But see that the relationship is kind of flat. But when we look at HFpEF in contrast, look at that, the relationship is pretty clear and sharp. So yes, inflammatory marker interleukin-6 is clearly related to progressive development of HFpEF inflammation. Okay, now let us look at the concept of understanding HFpEF. We know that if we look at a cardiomyocyte, we have the actin there, the thin filaments, and the myosin there, the thick ones. And of course, we know that the interaction between actin and myosin generates the force for the muscle contraction. But we should not forget the collagen fibers that lie interposed between the myocytes. Right. And we also know that there is something that we normally don't talk about, is that little spring there that connects between actin and myosin, and that turns out to be titin. Now, titin is one of the largest proteins. It is the largest protein in human body, and titin looks basically like a spring. And we today know that the titin can change its morphology, its expression from N2BA to N2B, from flexible to stiff, and that today, along with excess collagen deposition, is thought to be the hallmark of HFpEF. Right. So if we look into the development of HFpEF, we know that estrogen deficiency, for example, and catecholamine surge create this exact milieu, an abnormal titin and excess of collagen fibers. Okay. Now, if we look into the entire concept in one single picture, it is here. We know that HFpEF is something that is heterogeneous. It is associated with obesity, dyslipidemia, hypoglycemia, hypertension, many such comorbidities. But then what is common is a systemic inflammation whereby we have a TNF alpha and interleukins going up. And that, as you can see there, goes into the vascular system, and then that creates a milieu where the vascular inflammatory cells, for example, the macrophage, gets out from the vascular system into the cardiomyocyte. And that over time creates abnormality of the myofibroblast, increase in collagen deposition. So first, the increase in collagen. Second, we know that there are a lot of mechanisms by which the systemic inflammatory response, the TNFs, the interleukins, and the interleukin-6, by increase of reactive oxygen species and reduction of nitric oxide, create abnormal elasticity of the titin. And third, of course, we know that there is alteration of destabilization of protein that adds to the picture. So what do we find basically? One, we have an inflammation. Interleukins are elevated. Second, we have increase in collagen. And third, we have increase in titin. So in fact, titin, collagen, inflammation. So inflammation-driven titin and collagen deposition in the myocyte turns out to be the hallmark of HFpEF in whatever kind of HFpEF subtype we are looking at. And this understanding is crucial in looking into the treatment fraction. For example, today we have data that if we look into the pathobiology of HFpEF, for example, this data looks at the protein expression in HFpEF. And we see that every protein that is responsible for inflammation gets upgraded, those green ones, in HFpEF. In fact, they've taken out myocytes in this particular trial, for example, from samples during open heart surgical procedure, and found that if you look into, that is hypertension with HFpEF. The black square is HFpEF. If you look into, for example, collagen and titin, you see that in HFpEF, clearly, collagen is an increased black bar, titin is increased. So collagen, titin, inflammation. And then that background, look at one of the old data that came in 2000, right? And this looked into beta blockers and the inflammatory markers in dilated cardiomyopathy, right? There's a small trial that looked into, for example, on the left you see interleukin 10, on the right graph you see TNF alpha, both inflammatory markers. Look at what happened. Control bar is clear, and the dark bar is dilated cardiomyopathy. See that there is significant increase in inflammatory markers in dilated cardiomyopathy. And when these patients were treated with beta blockers, look at that, there's a very clear reduction of both interleukin 10 and TNF alpha. So post beta blocker treatment, it clearly came down. So yes, inflammatory markers were elevated in DCM. We treated them with beta blockers and they did actually come down. And that is the connection between inflammation and beta blockers. Okay, but let us directly go to HFpEF. Now, HFpEF for the clinician is this, right? You can see that, okay, there's a lady, 65 years, obese, came with pendopnea. Okay, you can see a JVP, it is atrial fibrillation. Look at an ECG, a fib, right? And then, if we look at an echo, for example, we see there is significant left ventricular hypertrophy. So we have left ventricular hypertrophy. Look at that large LA. Okay, so we have left ventricular hypertrophy. So what do we have? We have left ventricular hypertrophy. We have good ejection fraction. We have a dilated left atrium. We have AFib in a lady who is 65 and overweight. Right. So it fits in, right? Now let us look into, do we have enough evidence of HFpEF in this lady? And yes, we have. There's the H2 FPEF scoring that we all use. Look at that. We have heavy, hypertensive, AF. Yes, this lady is overweight, she is hypertensive, and she has AFib. Yeah, so that itself gives us what? 3 plus 2, 5 plus 1, 6. And if we have, she is elder, more than 60, we have one more. And of course, Doppler showed an abnormal filling pressure. So what do we have? Anything above 6 is suggestive of HFpEF, and here we have about 8. So clearly HFpEF. So we have HFpEF in our hands, right? So we have HFpEF with us. Now let us go to HFpEF and beta blockers. Do we have the data, right? Do we have the data? Now let us look into this large set that came in 2017 in JACC, looking at heart failure with reduced ejection fraction, a 5-year outcome. Right, this is 2017. And if you look into this data, this looked into heart failure, HFpEF, HFrEF. Look at that blue, that is HFrEF, and look at the gray, that is HFpEF. 46% of the heart failure were HFpEF. Right. And if you look into the 5-year mortality, surprisingly, whether you have HFpEF or HFrEF, the lines are similar. So 5-year mortality looks similar whether you had HFpEF or HFrEF. So as bad an outcome like HFrEF, and the incidents were almost similar. That was a good learning, right? Now, if you look into the groups of HFrEF on the left and HFpEF on the right, okay, and look at the HFpEF, look at the discharge medication, 70% were on beta blockers. So even without any study, a large percentage of patients of HFpEF are on beta blockers. Because there must have been an indication, some other indication for beta blockers. Their heart rate might have been rapid, they might have had AFib, they might have had hypertension, they might have had coronary artery disease. So there is some other indication. So 70% in real life of HFpEF got beta blockers. Okay, now fast forward 2021. This is when the problem started. In 2021, this data came out, which was subject to a huge amount of discussion, a couple of strong editorials that looked into withdrawal of beta blockers on functional capacity in patients with HFpEF. So patients of HFpEF who had chronotropic incompetence, beta blockers were withdrawn to see do they benefit. Beta blockers were withdrawn in HFpEF with chronotropic incompetence to see did they benefit. So NYHA class 2 and 3, HFpEF, chronotropic incompetence. And they were just 52 patients. Just 52 patients. Right. But what it showed was unusual. It did show that if you look into the peak VO2 in the y-axis, the blue bar is beta blocker continued, red is beta blocker withdrawn. You see that on withdrawal of beta blocker, the peak VO2 significantly increased. Right. So patients felt better, which means that in a patient of chronotropic incompetence, if you withdraw beta blocker in HFpEF, they improve. And so this became a big news. Beta blockers in HFpEF are bad. But it is wrong. I'll show you why. Even in this group where they symptomatically improved, let us look at their NT-proBNP. In the beta blocker withdrawal group, the NT-proBNP clearly increased. Of course, the p-values are not significant. But the trend was not favorable. On withdrawal of beta blocker, clearly the NT-proBNP levels increased. Now, more importantly is this. If you look at the treatment of these 52 patients, they were on ACE-ARB 75%, diuretics 84%, MRA, statins. Okay, but where is the SGLT inhibitor? No SGLT inhibitor. What is the treatment for HFpEF today? We clearly know treatment for HFpEF is SGLT inhibitors. So HFpEF patients need to be on an SGLT inhibitor in today's modern era of therapy. Now the question is, patients of HFpEF on SGLT inhibitor, do they benefit by beta blocker? That question was not answered here. But this made big news and people said beta blockers are not good in HFpEF. Anyway, this data came in 2023 They looked into beta blocker in both preserved and mildly reduced ejection fraction. And they said clearly there's benefit in mid-range ejection fraction, mildly reduced ejection fraction, but not in FPF. But let us wait for a moment and actually look into the data supplied by the study. They said no benefit in FPF, but look at that data. When they drew a graph where they looked into death and heart failure hospitalization as an end event, look at that. The LV ejection fraction in the bottom x-axis, 40, 50, 60, 70, 80. And we are looking at death and heart failure hospitalization. Look at that. Till an ejection fraction of 70, it tended to benefit. Till 70. Okay. And when you looked into death alone, again, till about 70 or 65%, that tended to be a benefit. Clearly, only when it crossed 70, we can see that the benefit was lost. In fact, if you look into the numbers, ejection fraction 40 to 49, very clearly benefit, 0.83. Ejection fraction 50 to 59, again, benefit, 0.92. Look at the confidence interval, 0.9 to 0.95, below 1. Clear benefit. Okay, both death and heart failure hospitalization, not death. Only when it crossed 60, you see the benefit was 0.99. So till 60% ejection fraction or below 60%, 50 to 60, clearly benefited by beta blockers. Only thing is you need to treat them with contemporary treatment, including SGLT inhibitors and perhaps non-hormonal MRAs. Okay, now this is the data that came on the use of beta blockers in heart failure, preserved ejection fraction, large data from a 41,000 patient data. They picked up 19,000 heart failure with preserved ejection fraction. 8,000 patients were propensity matched 2:1. 8,000 patients were propensity matched, right? Age 76, half of them were 46% women. Okay, and if you look into the data, we'll go quickly. Survival on left, survival free from heart failure on the right. And very clearly, if you look at those on beta blockers in orange line, did far better than no beta blockers. Whether you looked into the matched cohort or non-matched cohort, very clearly beta blocker clearly had a survival free from heart failure hospitalization better than those who were not on beta blockers. So patients on beta blockers did better. But then there's a retrospective cohort. Look at the sub-analysis, ejection fraction more than 50 or 40 to 49. They had similar degree of benefit with no, the p-value interaction was not significant, so they were homogeneous. So benefit was homogeneous, like p interaction was 0.99. Okay, now if you look at the contemporary use of what we said, SGLT inhibitors, and on top of that, what happens if you use beta blockers? This came from the DELIVER trial, a trial which was looking into dapagliflozin and heart failure, right? Dapagliflozin and heart failure, 5,077 patients, 177 patients, 83% beta blockers, and all on DAPA. So patients, this is what we are looking at. Patients on SGLT inhibitor did the benefit on beta blockers. Patients on HFPF, all on SGLT inhibitor, did it make a difference when we added beta blockers? Right. And when we looked into the data, surprising, no beta blockers on left, beta blockers on right. Look at that. Primary composite events, much lesser when there was beta blocker on board. 10.6 versus 8.3. Right. Look at the heart failure events, 7.8, 6.1. Benefit. Look at CV death, 4.6, 3.3. Look at all-cause death, 8.3, 7.2. Numerically, all these events, whether it's a primary composite, heart failure event, cardiovascular death, or all-cause death, they were lower in patients treated with beta blockers, provided they were on SGLT inhibitor. And that's what we are trying to tell you. When you give contemporary treatment to patients of heart failure, HFpEF, with SGLT inhibitors and perhaps non-hormonal MRAs, beta blockers do clearly benefit. Okay, and look at the graph here. No beta blocker in blue, beta blocker in red. Very clearly, when you look at cumulative incidence over a 3-year period, beta blocker group did better, provided they were on SGLT inhibitors. Right. Now, finally, and look at that. Now, very interestingly, if you look at the graph that they're given, where on the x-axis you have the LV ejection fraction, and on the y-axis you have the rate ratio. Look at that. look at that. Actually, what happens is, as the ejection fraction increases, the benefit increase, right? So in HFpEF, when you have an SGLT inhibitor on board, giving beta blocker improves their outcome very, very clearly, right? And if you look at one of the largest data, we'll finish with that came retrospective data of beta blocker therapy, 12,000 patient beta blockers, 7,000 no beta blockers, all-cause mortality down 0.73, hazard ratio 12-month post-hospitalization down 0.74. And you see the p-values, very, very significant. So if you look at the conclusion of this large data of 20,000 patients of HFpEF, 20,000 patients of HFpEF, look at that. The mortality benefit persisted in those treated with spironolactone and ACE or ARB. So the beta blocker benefit persisted in those treated with ACE or ARB and spironolactone and those with AFib. So yes, very clearly, the point is in HFpEF, we need to reconsider beta blocker withdrawal. Don't withdraw beta blocker unless your patient has chronotropic incompetence. If your patient is feeling worse, symptoms are worsening, and there is chronotropic incompetence, you can give a trial of slowly reducing your withdrawing beta blocker. But don't go home with an idea that beta blockers for HFpEF are bad, right? So where are we? Professor James Black died in March 22, 2010, and perhaps a tribute to him is to say that yes, his beta blockers are good for patients of HFpEF too, provided we choose carefully and treat them with evidence-based medicine. Thank you for your time and attention.
Thank you, Dr. Tiny, for that wonderful presentation. As sir could not join online, I think we'll directly go to the case presentation. I invite the examiners, Dr. R.J. Manyuran, Dr. Sudhir Kumar, Dr. Surendra Diora, to take over the session. I invite the case presenter to start presenting the slides.
Good evening, everybody.
Yes, sir.
Which institution is presenting the case?
Sir, KEM Mumbai.
KEM
Sir.
Hospital, JS Medical
Yes.
College and KEM Hospital.
KEM and what is the?
Yeah, can you go to the first slide, please?
Okay. And KEM, yeah. One question. What is the name of the presenter?
Zulkar, sir. Dr. Zulkarnain.
Okay.
Dr. Sulkar.
Yes, sir.
Okay. Can we start? Please start. Sudhemar, can we start, Sudhemar?
Yes, sir. Discussions, they have two discussions also. He is presenting and we have two
Sulkar is
discussions
presenting.
from,
Yes, sir.
then there are two discussions from AIMS, Ludpur or something. They are not there.
Good evening, sir.
Ankit.
Yes.
Okay.
What are your names, please?
Sir, Ankit, sir, Dr. Ankit, sir. Dr. Kuldeep.
Ankit and
Kuldeep.
Kuldeep. Okay. Okay, start.
Good evening, everyone. Today I'll be presenting a case of Mr. S. He's a 61-year-old male. He has been formally educated till 10th standard. He's a manager at a catering place and resides in Parel village, Mumbai. He presented with the chief complaints of dyspnea on exertion since the last 1 year and swelling of bilateral lower limb since the past 4 months. So the patient was in the usual state of health when he developed breathlessness, which was initially present only on exertion, that was NYHA class 2 and present only on exertion, and gradually progressed, and now is present even at doing his household activities. The patient has had repeated episodes of worsening breathlessness with NYHA class 4 associated worsening of symptoms on lying down. The patient has had 4 admissions in the past 1 year for worsening symptoms and required IV injections and oxygen support for
The problem with the
symptoms.
video.
Sir? During this episode, the patient was diagnosed to have
Yes,
a
go
cardiac
ahead.
disease. During this episode, the patient was diagnosed to have a cardiac disease for which he was prescribed various pills, one of which was, he said, increased his urine output. The patient also gives history of swelling of bilateral lower limbs in the last 4 months. which started around the ankle joint and has gradually progressed and now is present up to the mid-thigh and is also associated with total swelling. The patient says that this swelling is aggravated on standing for a long time and is relieved on lying down with his legs elevated. The patient does not give any history of cough, hemoptysis, seasonal variation of breathlessness, any history of chest pain, palpitations, syncope, pre-syncope, puffiness of face, or abdominal distension. The patient does not give any history of decreased urine output, any frothy urine, yellowish discoloration of eyes. Past history is significant for the patient being a known case of type 2 diabetes mellitus. Since the past 6 years, he is on oral hypoglycemic agents for the same. He has no other significant comorbidity. Family history is not significant. The patient does not have any similar complaints in the family. He has no history of sudden cardiac death in the family. With respect to his personal history, his diet is mixed, his appetite is reduced, his sleep has been disturbed because of the history of orthopnea. He has complaints of constipation and his bladder is regular. He denies any addictions. The patient's socioeconomic status by Kupuswami's classification is lower middle class. Treatment history. The patient has had repeated admissions in the last year. The most recent admission was in March 2025 when he had also undergone some procedure from his right groin and he was told that he has some cardiac problem for which he has to undergo an open heart surgery. Since then, the patient has been on multiple medications and he is compliant to them. To summarize the history, we have a 61-year-old diabetic male who presented with NYHA class 2 dyspnea in the last 1 year with episodic worsening of breathlessness with 4 hospital admissions for presumable ADHF and also complaints of fetal edema since the past 4 months. I would at the end of the
I think
history.
we'll ask the
No. I
Ankit.
think you
Am I
can
right, sir?
hold on. No.
Yes, sir.
There's no need. You can take
Just
away the
go
slide.
back. Don't display the slide.
Don't display the slide.
The previous one.
Yes,
Go to
sir.
the previous one. Okay, fine.
Okay.
Fine.
That's enough. So shall we ask the AIMS group to discuss the case? Ankit and
Sir,
Kuldeep.
Sir, I have a few comments on the presentation.
Okay, yes.
Certain things which you can modify,
Yes, sir.
associate with worsening of symptoms. At postgraduate level, you need not beat around the bush. You can say the patient orthopnea, no paroxysmal nocturnal dyspnea. You have to tell them, and
Yes,
no
sir.
bendopnea. So no, we have to tell that.
Yes, sir.
We are giving you suggestions how to modify that. Okay. Prescribed various pills, one of which was increasing urine output. You can say he was prescribed drugs, including diuretic.
Yes, sir.
And you will get an idea about other drugs also. So we need not be very diplomatic. Okay. Next slide, please. Next slide. Like that, a few suggestions. Next slide.
Yes, sir.
Okay. Fine. Next slide. When you talk about diabetes, it's an important thing. Even though we are practicing cardiology, you will get patients with diabetes. The type 2 diabetes in 6 years on OHS, it is fairly controlled. There is no clinical or documentary evidence of neuropathy, retinopathy, or nephropathy. Nephropathy, retinopathy, or neuropathy. You have to tell that because cardiodiabetic metabolic syndrome, it's a very important thing. So you are not a pure cardiologist. So we have to go into all the details. This is the comment about your presentation.
Yes,
Okay,
sir.
sir.
I also felt that he didn't mention about paroxysmal nocturnal dyspnea. That was a very important point because that's a very important, either it's positive or negative, that's a very important
Yes, sir.
story. That I think you should definitely mention because that definitely distinguishes definite left heart disease from, we are not so certain about the left heart disease. It could be a pure right heart disease also. So
Yes.
that definitely should be mentioned. Then, of course, as Zemar has rightly pointed out, some of the history minor details you can cut short by drawing a conclusion. So you can make use of a term, but you can always tell that this patient was given diuretics. So that you may not go on describing that he was given a tablet which increases urine output and all, because it's a diuretic that you have concluded that. So some conclusions can be drawn so that the message can be conveyed in a shorter manner.
Yes.
Now, shall we ask the
Say
Yeah.
one more thing regarding the comments. Don't say that you underwent a procedure through the right groin. What was the procedure other than cardiac catheterization? What do you know? So say that the patient underwent a heart cardiac catheterization for a right groin approach or right femoral approach. Don't say open heart surgery. And for example, CABG is not open heart. So he was advised cardiac surgery. We don't know what was the surgery. Open heart means we are going for surgery inside, whereas CABG is not open heart. So that is a misnomer which we are using routinely, patients as well as doctors. Okay, sir, go
No,
ahead, sir.
unless the patient has told him that
Yeah.
he was told that I have to undergo an open heart procedure. If the patient has told that, I think it is a story that you are obtained from the patient, and that can be told. You cannot
Sir,
conclude that it is an open heart procedure.
Sir, even if the patient says, all the patients say open heart surgery, we also talk. Because if you say, or you can tell, patient may say, you can ask, what was the surgery recommended? You can tell that. Was it
But
valve surgery?
in general,
You can,
Sudhaiman,
you can.
actually, when we say open heart surgery, we usually mean that he has to undergo a cardiopulmonary bypass and undergo surgery, because everybody knows that
That's right.
you are not opening the heart. We know in CABG.
CABG.
But what we usually aim at is that these patients have to undergo a cardiopulmonary bypass and then undergo the surgical procedure. That's what I understand. And so CABG is considered as a procedure as an open heart because of the cardiopulmonary bypass.
Earlier. Now it is off pump, sir, CABG. CABG is off pump.
Yeah, yes, it can be done with pump heart.
Okay, fine, sir.
Mostly it is the other way around. That's why.
But simple thing is say he was advised cardiac surgery. That will be the simple thing. Okay, sir. You go to Ankit, the turn.
Okay, we'll ask the other group to discuss the case. Agit and Kuldeep. How will you proceed to discuss? First question I would ask myself is that what is the system affected? Because I start from the elements. So the first question is what is the system affected? And then gradually build it up.
Yes, sir. As there are complaints of dyspnea on exertion, sir, NYHA 2 to NYHA 3 over last 1 year, sir, without any history of any fever associated with cough or any seasonal variation, and also, sir, there is also associated swelling of bilateral lower limb for last 4 months. Predominantly, cardiac system is involved, sir, in this case.
So since there is a history of edema of the lower limbs and exertional breathlessness, which are cardiovascular symptoms, you think that is cardiovascular system is affected. All right. Which side is affected?
Left heart failure, followed by the right heart failure.
Okay.
Pedal edema.
Why do you want to say
can
that?
Ask, okay, sir. Go ahead, sir.
Why did you say that the left heart is first affected, followed by right heart involvement? What is the evidence?
So dyspnea exertion as well as PND complaint and the history of the PND.
There is no history of PND. I didn't hear him saying there is a PND.
No, sir.
No history of PND. And his symptoms started with edema of both lower limbs, and symptoms were more like right heart disease than left heart disease. And in right heart disease also, there can be sometimes exertional breathlessness as an important symptom, especially patients with primary pulmonary arterial hypertension. About 80% of them present with exertional breathlessness. So there are many explanations for there are many reasons to explain how there can be breathlessness in patients with right heart failure. Can you mention few theories about the symptom of breathlessness in right heart failure? Agil.
Yes, sir. Abdominal distension due to the abdominal distension also.
That all right. Okay. More important than that.
Discuss about
how the septum works.
Okay. What did you say?
No, I was asking Ankit about what is the role of interventricular septum. The right heart fails, what happens to LV, ETP, and other left side. That you have to discuss.
Interventricular septum shift towards the
LV side. So LV cavity, LV filling volume also reduced down. So the dyspnea on exertional dyspnea can occur
There can
due
be
to the
reduced,
RV volume overload.
can be reduced filling of the left ventricle.
Yes,
The left ventricular cavity is encroached upon. So there can be something like elevation of the diastolic pressure, resulting
yes.
in the patients can have. The dyspnea means mostly when cardiovascular dyspnea means there is elevation of the pulmonary venous pressure. And at what level does the patient start developing dyspnea? What is the normal pulmonary venous pressure? What is the normal pulmonary venous pressure? Up to what level? You consider as normal. At what level do the patient start developing symptoms of breathlessness? And at what level does the patient develop pulmonary edema?
So more than 25 pulmonary edema.
Okay.
Normal.
Mostly.
Normal.
What
First
is
you
the
say.
The normal.
Sir was asking about normal pulmonary
Yes,
venous
sir.
pressure and what happens when it rises progressively. That is Sir's question.
Yes. Normal pulmonary venous pressure, that is around 8 to 10 millimeter mercury.
Okay, some people say up to 11. 11 can
Yes.
be considered as the upper limit of normal. So we can say that normally it is around 8 or 9, but it can go up to 11, which can still be considered as within normal limits. Beyond that, at what level does the patient start developing symptom of breathlessness?
12 to 18 millimeter of mercury.
Yes, around near about 15 to 18, the patient definitely starts developing symptom of breathlessness. Yes.
And
More than
and it will increases if it is more than 25, then he will be having a complaint of pulmonary edema.
progressively,
Yes.
sir, there can be capitalization of the vessels on the chest X-ray. We can also appreciate in between the 20 to 25 also, and there is a curly B lines also can be appreciated, and more than 25 there will be frank pulmonary edema, sir.
Yeah, when it goes beyond 25, of course, in patients with chronic pulmonary congestion, sometimes the pulmonary edema occurs even at a higher level. Patients with mitral stenosis may tolerate even up to 30 millimeters of mercury, and they may develop pulmonary edema only when it exceeds that. But usually, 25 is considered as the level at which patients can go for pulmonary congestion, pulmonary edema. So, in this patient, definitely pulmonary venous pressure is the definitely cause for development of breathlessness in a patient with cardiac problem. So when there's a right side involvement, how will you explain? And you have already said that there can be septum and deviate to the right and left, encroaching upon the LV cavity. Any other mechanism?
Yes, sir. Like this, sir. One is comorbidity, sir, diabetes, sir, and with and also, sir, like heart failure with preserved ejection fraction, there will be raised LVEDP, sir, leading to raised backward
Now
pressure.
the
Leading to,
question is, Sir's question is, how will you explain the symptom of dyspnea in right heart failure? We are not discussing primary left heart problem. That is Sir's question. So whenever you are asked a question, study the question and answer to the question. That is very important in the examination as well as discussion. Okay. Sir's question you take and discuss that. If you're not sure, you say that we are not sure, so we'll teach you. Okay.
So do you know
Okay.
that patients with right heart failure can present with breathlessness?
yes, yes.
Yeah. So one mechanism you have already told. Another is the heart is a syncytium. So there is a thought process that since the heart is a syncytium, when the right heart is significantly involved, there can be effect on the left side also. Third is there is something known as Turger effect. Do you know Turger effect? Where does the coronary sinus drain?
RA.
RA. When there is a right heart failure, what happens to RA pressure?
So it is increased.
What happens to RA pressure?
It
Increases. When there is a venous drainage of the heart coronary sinus, pressure increases. What will happen to the myocardium? Will there be any transudation of fluid into the myocardium? Because there is a venous pressure is elevated, that can result in myocardial edema, and myocardial edema can give rise to reduced compliance of the left ventricle, and the patients can have elevated left ventricular filling pressures, and those patients can develop breathlessness. Then there are many other mechanisms like pleural effusion. Then the patients can have sometimes in patients with pulmonary arterial hypertension, it can compress upon the bronchus, can give rise to sometimes partial collapse of the lungs. And then there is a J receptor stimulation. There are many mechanisms, and also definitely the exercising muscles, that is the intercostal muscles and exercising, especially patients with dyspnea. When there is intercostal muscles are deprived of blood supply because of the reduced cardiac output, these patients can develop a tired phenomenon which manifests as breathlessness. So then there are multiple mechanisms. And as you have also said, patients with ascites can have breathlessness. So there are many reasons for development of exertional breathlessness in a patient with right heart failure. So you cannot definitely say that because of breathlessness, I would consider only left heart symptoms. I think you should keep your mind open. I agree with you that most important reason for breathlessness is left heart involvement and not right heart involvement. But right heart also can give rise to the symptoms because of multiple mechanisms.
So,
Okay.
shall I, sir?
Yeah, please.
Now, your approach, as sir said, cardiovascular system is all definitely affected. Then my approach will be, what is the hemodynamic abnormality in this case? Then only you can localize to left heart, right heart, severity, all those things. So what is the basic hemodynamic abnormality in this case? It is systemic venous congestion for the last 4 months. And we find that patients with isolated right heart failure seldom present with edema, gross edema. Because the mechanism of edema in heart failure is not primarily systemic venous congestion. There is only aggravating factors. It is a reduction in the cardiac output leading to renin, angiotensin, aldosterone mechanism, neurohumoral factors resulting in fluid retention, all those things. So in isolated right heart failure, edema is relatively, it is contributed by the other factors also. That is one. So you start saying that the patient started with symptom of breathlessness, with progress to class 4 in between, requiring hospitalization. So the common condition is pulmonary venous hypertension. So it's a left heart problem. Because the patient has class 4 symptoms and orthopnea, you can say if orthopnea can be due to other things, but in cardiac, it indicates the pulmonary capital pressure is gone up to more than 25. The only point which I want to discuss about acute pulmonary edema and the pulmonary capillary pressure is acute pulmonary edema is usually precipitated by a triggering factor which raises the LA pressure or the pulmonary capillary pressure suddenly. And acute pulmonary edema in natural history of a heart disease, it's an early phenomenon. It doesn't occur in chronic cases because in chronic long-standing cases, there'll be changes occur in the pulmonary capillaries, interstitium, all those things. So the transudation to the alveoli is restricted to some extent. The lymphatic system will be dilated, that will be draining the fluid. So natural history of a chronic heart failure or a chronic heart disease, PND, pulmonary edema is relatively early. And there will be a factor which triggers that acute pulmonary because there should be an acute rise in the pulmonary capillary pressure. So that is so. Here is a chronic progressive pulmonary venous hypertension. That will the way commonly be approached. And he has gone in for right heart failure, which indicate that the patient has systemic venous congestion plus contribution by the renin, angiotensin, aldosterone, sodium water retention, and plus so many other neurohormonal factors. The second thing which I want to discuss or to expand or add, which sir said, heart failure, symptom of breathlessness in right heart failure. Breathlessness in heart failure is predominantly pulmonary venous congestion. Second is the low cardiac output. They also present with inadequate oxygen delivery to the respiratory muscles. They've left tachypnea, fatigue of the respiratory. No, it's fairly common. So it is a low cardiac output which contributes to that. So in right heart failure, the cardiac output can come down. Then the second is the oxygen carrying capacity or oxygen delivery to the respiratory muscles is less. The brainstem gets stimulated. So desaturation can occur. When there is a high right atrial pressure, the intravenous septum may stretch open and there can be a right to left shunt. Even though theoretically or by practice, it's a topic for you. That is intravenous that is catheter management, restricted in-rate opening to decompress or to improve the cardiac output. That is being well described. Decompress the left atrium to the right atrium. So in this situation, when there is severe right heart failure, the right atrial pressure may go up, the in-rate septum may stretch, and there can be stretch opening of the foramina veli, and there can be a right to left shunt leading to some degree of desaturation. Then, as we have said, other factors. This is the way I approach this case. Now, basically, the common thing, as you have said, it is a left heart failure chronic, progressing to right heart failure. So, why did he develop right heart failure in a patient with left heart disease? So, is it that the right heart failure is the consequence of left heart hemodynamics, like pulmonary hypertension, or is the basic disease affecting both the ventricles, or is there something contributing to myocardial depression or things like arrhythmias? Common arrhythmia which precipitates right heart failure in a patient with gross primary left heart failure will be atrial fibrillation, especially diabetic 61 years. So, these are the things which you have to keep in mind when you discuss this case. Am I right, sir?
Oh, yes, yes. One point, say, when the patient is having chronic left heart symptoms, usually the pressure which is required to cause pulmonary edema actually goes up. Very often at 25 it may not happen. The patient, the pulmonary venous pressure sometimes even of 28 may not develop pulmonary edema. It may go up to 30 or even more than that. As this happens usually in patients with mitral stenosis with chronic pulmonary congestion. What is the mechanism which results in a higher tolerance in these patients who have got a chronic pulmonary congestion? Sudhir Marini's description has actually mentioned that on the during the discussion. So I want to find out whether you have really got the message. Why
You are
the
putting
patients
me
can
under stress, Angit, Kapil, and Sutkar.
Yes.
Okay.
can you explain how the patients with chronic pulmonary congestion can tolerate higher pulmonary venous pressure? Yes, already mentioned when the pulmonary venous pressure goes up, there is transudation of fluid, and this fluid is drained by what? Lymphatics. The lymphatics become more efficient, and there can be some degree of interstitial fibrosis. All these can, to some extent, reduce or rather increase the tolerance for pulmonary venous congestion, and the pulmonary edema occurs very often above 30 millimeters of mercury. Very often in patients with chronic mitral stenosis patients, they can tolerate pulmonary venous pressure even up to 20 or 25, up to 30. Can you tell me one situation where there can be pulmonary edema at a much lower pulmonary venous pressure at 20? Can you tell me a situation where there can be development of pulmonary edema at a lower pulmonary venous pressure?
Acute mitral regurgitation.
Not mitral regurgitation. Mitral regurgitation, no, say it is a transudation of fluid. It's a venous congestion, transudation of fluid. The transudation fluid is controlled by what? The osmotic pressure and the hydrostatic pressure. If the osmotic pressure comes down, then at a lower hydrostatic pressure, the patients can develop pulmonary edema. So in a patient with hypoalbuminemia, the pulmonary edema may happen even when the pulmonary venous pressure is only 20 millimeters of mercury. Okay, go ahead. I think we'll have to go ahead. Okay.
Sir, one more point I want to ask. A usual question which was asked to us earlier. In mitral stenosis, as the mitral stenosis progresses, we have three symptoms. One is pulmonary edema, we have orthopnea, and paroxysmal nocturnal dyspnea. Can you tell us which occurs first or the temporal relation? You may not answer that. Okay, pulmonary edema occurs early because of the mechanism which we have said. In chronic cases, there will be protective mechanisms which prevent translation of fluid into the alveoli. Okay. Now, between orthopnea and paroxysmal nocturnal dyspnea, which is more severe? Any idea, Ankit? Pardon?
Orthopnea.
Why? You are right, but you have to explain. What is orthopnea?
Uh,
Dyspnea on lying down and relieved by sitting up.
Yes.
But why orthopnea is more ominous than PND? The mechanism. In orthopnea, the patient lies flat. The only thing is the volume. The venous return increases to the left atrium. The venous pressure rises because of a single factor. Whereas in paroxysmal nocturnal dyspnea, it occurs later. So it has multiple contributions. I think you should read that. We are not going to discuss the mechanism which we have already discussed in the previous classes. The paroxysmal nocturnal dyspnea occurs later. Not only the venous return increase, shift of the extracellular fluid to the intravascular compartment, neurohumoral, so many things. So between orthopnea, classical orthopnea, not lying down and dyspnea, the patient lies down and become breathless and gets up. It occurs immediately. So the only fact which triggers that is the volume increase, that is venous return, postural increase in the venous return to the heart. Okay, go ahead.
Now, one more thing. See, when you think of orthopnea and paroxysmal nocturnal dyspnea, you should remember that paroxysmal nocturnal dyspnea is a 100% cardiac symptom and it indicates left side heart disease. But orthopnea is not a 100% cardiac symptom. This can happen in patients with respiratory illness, patients with ascites. They can also have orthopnea only means there is breathlessness or difficulty to lie down. So sometimes this can happen in patients with non-cardiac illness also, like respiratory illness, like pleural effusion, pneumothorax, or all these patients can also sometimes be orthopneic. So you should be careful that orthopnea, of course, is a more severe symptom than paroxysmal nocturnal dyspnea, but then you should also exercise enough precaution to make it certain that the patient is orthopneic because of the cardiac illness.
So there was a question from the audience, Burnham effect. Burnham effect is septal hypertrophy bulging to the right heart, so that it interfering with the right ventricular filling problem. If this occurs, we call it as the reverse Burnham effect. That is, the septum is bulging to the left heart, interfering with the left ventricular dynamics. That is reverse Burnham effect. There was a question in the chat box. Okay, go ahead.
No, don't project it. No, not it. See, now you have to, after hearing you should tell us what is your probable diagnosis.
Sir, after the
Different
history of
diagnosis, you can, the presenter should project only when we say you can project. Understand, Dr. Sulkar?
yes, sir.
You should project only when we say you project your next slide.
Yes, sir.
Otherwise,
Yes,
there is
sir.
no discussion.
Yes, sir.
Because you know the diagnosis, they do not know the diagnosis. We are training them to think how to come to a clinical diagnosis before you examine the patient. So you have to
Yes.
project only when we say yes. Okay?
Yes.
Right. So Ankit and Kuldeep.
Yes, sir.
Kuldeep.
Kapil, Allah.
Kapil.
Kuldeep.
Yes, sir.
Is it Kuldeep or Kapil?
Kuldeep.
Kuldeep.
Kuldeep, yes.
Kuldeep.
So would you like to come forward with a diagnosis or a differential diagnosis?
Our first differential diagnosis will be cardiomyopathy, dilated cardiomyopathy, since it is now on exertion and having a history of pedal edema.
Dilated cardiomyopathy. But dilated cardiomyopathy mostly affects the left heart, and 80% it is a left dominant involvement. And these patients will have more profound left heart symptoms. I would expect some history of paroxysmal nocturnal dyspnea. Nothing is there. So I do not know whether that could be the first possibility.
But your approach, sir, I will discuss left heart disease as the primary thing.
Okay.
Okay, you can have an open discussion. Which are the left heart diseases which can produce heart failure? The first part is it pure left heart failure to right heart failure or isolated right heart failure? Statistically, we go for left heart failure.
I think
with all
the second part also I would like to give due importance whether this could be a purely right heart disease and other symptoms can be explained by the different mechanisms.
So what you have to do is it a left heart disease to right heart failure? Predominantly right heart start from the pulmonary arteries and proximally and pericardial disease. This should be our approach to the case, differential diagnosis. So personally, I think that the commonest, okay, sir.
Go ahead. Do you have any
I am having
diagnosis? Any diagnosis that you would like to put forward?
Sir, as there are multiple admissions because of ADHF, sir, so there must be some NYHA4 in between also. So we would like to have primary left heart disease leading to right heart disease as a first provisional.
Okay.
Then, sir,
Do you think there is a left heart disease which has progressed to right heart disease? Okay.
yes.
Right.
Okay,
Yes.
go ahead. What
So
are the possibilities then?
Possibilities. Then you say possibilities.
Which are the diseases in the left heart? Don't jump to diagnosis of this thing because it could be anything. We are not sure. So which are the common left heart diseases? Okay, starting from valves, aorta, myocardium. So don't jump to dilate cardiomyopathy or restrictive cardiomyopathy. So we have to see whether it is a primary left ventricular myocardial problem or is a left ventricle fail, left heart fail because of overload, volume overload or pressure load. That is the way you have to approach. And we can exclude so many things. But if I ask you, can it be valvular heart disease? Can it be valvular heart disease?
Okay, you said that it is actually initially it started with a left heart disease and went into right heart disease. I am saying that I am of the opinion that this must be a right heart disease since there is no history of paroxysmal nocturne dyspnea and most of the symptoms can be explained by the right heart disease. I would like to go that it is a right heart disease and the patient has got florid features of right heart disease and all symptoms can be explained. In that case, what is your approach? What are the, can you tell me a few conditions where there is a purely right heart disease and the patient has developed all these symptoms?
Sir, one is pulmonary hypertension, sir. Primary pulmonary hypertension.
Okay.
Primary pulmonary hypertension. That is a 61-year-old man.
Sir, age is not mentioned, sir.
61-year-old man and very primary pulmonary artery hypertension. I will not give a. And also, what is the important story that would help you to think that it could be primary pulmonary artery hypertension? One symptom which is very may immediately make you think that it could be something like primary pulmonary artery hypertension. Do they develop any special exertional symptom?
The cardiac output is very low in these cases. Yes.
So when they exercise, what happens? They can go for syncope. Syncope is an important symptom which will give you a clue that there is a if you are considering primary pulmonary artery hypertension, history of syncope will further support the diagnosis. Here, there is nothing to suspect that there is a pressure overload.
And pulmonary hypertension primary, as you have said, A, and from the very early the patient has gone in for severe congestive heart failure. Once the primary pulmonary hypertension goes for congestive heart failure, their survival is very limited. Okay.
Usually, sir.
So that's a diagnosis which you should make last, not primary pulmonary hypertension. The pulmonary hypertension, sir, thereby look at whether other conditions. You will be asked questions on that. So as you have suggested, when you talk about right heart failure, start from the pulmonary artery, the right ventricle, tricuspid valve. Like that, you have to progress. So when it is pulmonary hypertension, idiopathic pulmonary hypertension should come last. So, sir, other causes. So you are dealing with a pre-capillary pulmonary hypertension because sir wanted this as a right heart disease. So the commonest is post-capillary left heart disease. So pre-capillary pulmonary hypertension, this will be the question that will be asked. Which are the conditions where you get pre-capillary? One is core pulmonary. Second is shunt lesions. Third is thromboembolic pulmonary hypertension and idiopathic. Thromboembolic and idiopathic pulmonary hypertension almost have the same prognosis when they develop severe PAH going in for right heart failure. COPD, you say that this patient did not have symptoms of COPD, so we are putting it low in the list. Then Eisenmenger syndrome. Eisenmenger syndrome also going in for severe congestive heart failure is very rare. They do not go for florid congestive heart failure, can occur in the terminal phase. It is relatively uncommon. Seldom we see that. So come back. What is the next is right ventricle. So you have to answer the question to sir. Can it be right ventricular disease?
So can this be a cardiomyopathy involving the right heart? And what are the problems that you can think about? Or is it something which is involving in the right heart, not a cardiomyopathy, but something different?
Constrictive pericarditis. Constrictive pericarditis can be think of.
Constrictive pericarditis. Do you think that this is constrictive pericarditis? Is there any point against the diagnosis of constrictive pericarditis?
The breathlessness is the initial symptoms. Constrictive pericarditis would present with generalized anaphylactic.
You are not clear to me. Is it something wrong with your transmission? I am not able to comprehend what you are telling.
Sir, constrictive pericarditis, breathlessness.
One thing. I just want to intervene because sir asked a question. Can it be something related to the right ventricle?
Yes.
I hope they have not answered that. Sir, did they answer?
arrhythmogenic right
No.
ventricle.
Let them say answers. I thought let them tell whatever they want to tell, then I
Fine.
can further ask
Fine,
questions.
sir. Fine, sir. Fine, sir.
So I thought it could be a right-sided involvement, progressively going in for these present symptoms. So what do you think the possibility that you would like to consider? In patients with constrictive, you are considering constrictive pericarditis. Constrictive pericarditis, edema is more frequent, or abdominal distension is more common.
Abdominal distension.
Abdominal distension.
Abdominal distension. What is the mechanism? And in this patient, is it edema or abdominal distension which was the most striking symptom?
He did not have abdominal distension.
He did not.
So absence of abdominal distension, where the patient has actually gone for stage New York Heart Association stage 4, very unlikely that it would be a constrictive pericarditis. Would you like to discuss any right heart involvement where there is not constrictive pericarditis, something different?
So right ventricular failure. What are the situations there can have right ventricular failure? It could be a pressure overload, it could be a volume overload, or it could be structural abnormality of the right ventricle or tricuspid valve. So that is the way you have to answer that question. The right ventricle is facing the pulmonary valve, pulmonary artery. It has its own problem in the myocardium, different possibilities, and it is dealing with the tricuspid valve also. So if you look like that, you may be able to tell 2 or 3 answers.
What is the condition where there can be right ventricular involvement, where the patient can present with features of right heart failure?
The right ventricle is very small, seen in the coastal areas of South India, now rare. Predominantly, it can affect both ventricles.
So, as rendo
There is some degree of
myocardial fibrosis.
And
yeah.
I think dominantly involving the right side, they can very often they will have biventricular, but dominant involvement is the right ventricular endomyocardial fibrosis, which is a restrictive type of cardiomyopathy. That also definitely can be considered. Do you know any other form of restrictive cardiomyopathy? Any other restrictive cardiomyopathy?
amyloidosis.
Amyloidosis, cardiac amyloidosis. Can this be cardiac amyloidosis?
And
Amyloidosis patients can quickly deteriorate over a short period. They are usually on the older age group. He is a 61-year-old person. He can quickly deteriorate. So, do you think that this can be amyloidosis?
You should read about amyloidosis because that will be a question. The IL and the transthyretin, all those things you have to read. And advances in amyloid. So be
Types
careful.
of amyloidosis, and if there is a amyloid case, that will be kept in the examination, and then we will have to discuss the case. Okay, so if as Zaimar pointed out, this is a left side disease and then going to right side, what are your possibilities?
So before that right heart, I would like to add something more. The chronic right heart failure, RVMF. Suppose there is a volume load of the right ventricle, which is a congenital heart disease, which they present with heart failure at this age group, severe right heart failure, and they develop atrial fibrillation also. What is that?
ASD.
There is a right ventricular volume overload.
Yes, ASD.
ASD.
Yes.
ASD. They remain minimally symptomatic for quite long, and at this age group, they can decompensate and present like this. So that should be kept in them. Then primary tricuspid disease, though rare, you have to discuss that. We have to discuss for completion sake. So
Swamar, I
when
want
it
to
comes
ask,
to
can I ask one question? In ASD,
yes, sir.
why do these patients usually, if you look at the natural history of shunt like VSD and PDA, actually the shunt comes down, the heart size comes down. But in a patient with ASD, as the age advances, many of these patients can have a huge heart. What is the mechanism?
Uh, in ASD, firstly, the RV volume overload is there. As and in the case of the RV volume overload, RV pressure overload also, it is RV pressure overload increases due to the isometric physiology. So it is the RV compliance is also
Be
decreased.
careful, be careful.
What are
Don't
you?
say that admixture physiology here, because you will be taken for a ride in cyanotic congenital disease. Okay, admixture physiology is in cyanotic congenital disease. Okay, be careful your term.
I want to ask you a question. In a patient with ASD, as the age advances, will the left right shunt increase, decrease, or remain the same? And if you are saying something is happening, then what is the explanation?
Increases, sir, as because, sir, LV wall stiffness or the left side pressure increases as the age advances because of LV wall stiffness. As the sir,
You should start saying that the shunt in a patient with ASD is decided by the compliance of the left ventricle and the right ventricle.
yes,
As the compliance of the left ventricle comes down and
decreases.
the right ventricle remains compliant, the left to right shunt increases, and these patients can have increase in the left to right shunt, resulting in the increase in size of the right ventricle, the increase in size of the right atrium, and that will result in increase in size of the tricuspid valve, and that can give rise to tricuspid regurgitation, and so there is a additional volume overload, and these patients can develop a huge right heart, and tricuspid regurgitation will go on increasing, and these patients can develop atrial fibrillation. So that is one thing which Sudhemar was pointing out, but there is no history to suggest that he had there is no congenital heart disease. So that is the only problem.
The point
Okay.
is we have to discuss all the possibilities and
Yes.
prioritize. Now we come back to left heart disease.
One more
I was
question.
strongly, yes,
Just
sir.
one more question, sir. Do you think that this could be a carcinoid?
What we said, primary tricuspid disease, though rare, the question.
Yes, sir.
Do you think that you can bring in carcinoid in this patient?
Sir, as a 61-year-old male, we can keep the possibility as a down the left, but we will also look for other symptom like flushing and
Yes.
there needs to be a
In
bronchospasm.
the examination,
Fine.
you should try to bring in as many different diagnoses as possible and exhibit your knowledge. That is a good method of showing to the examiner that I know all these conditions, I have thought of it, and I have excluded it. So, the flushing and development of progressive,
Diarrhea, abdominal pain.
the lot of other symptoms may also help you to think. So here, none of these symptoms are there. So a carcinoid is a very far-fetched diagnosis. Yes. Left
Sir, I
side.
would like to discuss the other things because I was in favor of the left heart disease
Yes.
with all the limitations. It could be either. But if it is a left heart disease, which is much, much more common than isolated right heart failure in an elderly, what we have seen, if I have seen 100 cases of uh, heart failure in a 60-year-old diabetic, majority would have been left heart disease. Regarding the symptom, patients may not show the typical physiological sequence, may not. We have to discuss that right heart straight away. Left heart, my question is, can it be valvular heart disease? That is one thing which you have to get. Is it primary myocardial disease or a overloaded ventricle? Obviously, aortic stenosis is unlikely because it doesn't have any symptoms. Mitral stenosis also at this age group is very unlikely. Which valvular lesion is likely to remain mild and progress and present with heart failure? Mitral regurgitation. You have to keep in mind the possibility of mitral regurgitation, which have been remaining minimally symptomatic and going in for end-stage heart failure. So that has to be kept in mind. Then hypertension is not a hypertensive, so we need not consider that. Aortic stenosis, we need not consider. Aortic regurgitation, okay, low in the list. Then we come to the possibility of left ventricular myocardial disease. If it's a left ventricular myocardial disease, what is the thing which you keep first in a patient with diabetic 61? Suppose you have seen 50 cases of left ventricular failure, then a 61-year diabetic, the etiology is most likely coronary, ischemic heart disease. So left ventricular systolic dysfunction or dysfunction, the commonest is ischemic. Then inflammatory is the eyes in left ventricular dysfunction. Ischemic, inflammatory, idiopathic, iatrogenic. Anyway, inflammatory presents with acute. So the first is ischemic versus idiopathic, cardiomyopathy. Then iatrogenic we need not discuss. Arrhythmias will be contributing to that at this age group. So arrhythmias can contribute to heart failure with other lesions remaining relatively less severe. So between ischemic and cardiomyopathy, which cardiomyopathy will you consider?
One question
So that
I
will be
want to
my
ask.
diagnosis.
What is the mechanism of heart failure in ischemic heart disease? What are the changes which ultimately result in heart failure in a patient with ischemic heart disease? Why do these patients with ischemic heart disease develop heart failure? Mechanisms.
Sir, like in this patient, sir,
No,
there
in
can
any
be.
patient.
Sir,
Not in this patient, any patient. What are the mechanisms of ischemic heart disease progressing to heart failure?
Sir, one is myocardial ischemia leading to decreased myocardial output, sir, cardiac contractility.
Ischemia, we have
That is
already.
hallucination.
What is the problem which leads to?
Sir, basically, sir, LV dysfunction. One is decreased cardiac output and one is cardiac remodeling, sir.
No, that's not the question. Why do they develop LV dysfunction in ischemic heart disease? The answer should be loss of viable myocardium, hibernating myocardium. Lower in the list will be stunned myocardium, then mechanical complications like mitral regurgitation, LV aneurysm, and arrhythmias. That is the way you have to look into, because I am answering because we have to save time, because it is
There are,
already 8:11.
there are 5 mechanisms usually patients with ischemic heart disease can develop heart failure. One already Sulaiman has said, post myocardial infarction, ventricular remodeling. 2. Ischemic cardiomyopathy, where patients can develop hibernation and progressive heart failure. 2. Mechanical complications like acute mitral regurgitation, ventricular septal defect. These patients can develop heart failure. Arrhythmias, especially patients with ischemic heart disease, can develop ventricular arrhythmias or may develop atrial fibrillation. They can develop heart failure. And mitral regurgitation. These patients can have ischemic mitral regurgitation and they can develop heart failure. So heart failure in ischemic heart disease, there are 5 mechanisms which you should definitely know, because students very rarely understand how there can be heart failure in ischemic heart disease. So you must understand that there are 5 mechanisms and you should be thorough with that. Okay.
It's important in planning the management. When it's certain things are reversible. Okay, then among the cardiomyopathies, dilated cardiomyopathy, restrictive cardiomyopathy, it may be difficult to differentiate, but we can discuss both. Sir, at 8:59, it's
Okay.
8:15
So
now.
okay, so we'll go to the we are considered two possibilities. One, left heart disease leading to progressive right heart failure. We also thought of the possibility of purely right heart failure also. Now we'll go to the physical findings. Shall we ask the presenter to continue with that?
Sulkar.
Yes.
Yes, sir.
This is Sulkar. Yes, Sulkar,
Yes, sir. Yes.
please.
Yes, sir. Sir, on general physical examination, he's an elderly male, well-built and nourished, conscious, cooperative, well-oriented to time, place, and person. Patient on examination was pale. There was no interest, sinuses, cluttering, or lymphadenopathy. Patient had bilateral pitting fatal edema.
And the
It was
previous one, the patient has, the previous slide, the patient has no cyanosis, no clubbing. Okay, fine. Be careful when you say he is well-built and nourished, because he is likely to have
edema.
what is called the gastrointestinal malabsorption syndromes, all those things. Okay, fine, go ahead.
As the patient had bilateral pitting fatal
Yes,
edema.
go ahead, go ahead.
The patient had bilateral pitting fatal edema extending up to the mid-thigh. He also had abdominal wall edema with total edema. Patient has left eye senile mature cataract. Patient has no evidence of xanthoma, xanthelasma, arcus senilis, or any carotid fluid. Patient's weight was 83 kg, height was 162 centimeter, with a BMI of 31.6 kg per meter square.
So at the beginning, you have said the patient is obese with a body mass index of 31.6, rather than saying moderately built. So you say that's not what is needed to your level.
Yes.
So he
No,
is
but
obese with a body
I don't
mass
know
index
whether
of 30.
what the patient with so much edema, whether the body mass index is a correct calculation, because
I agree with you, sir. I
another
agree.
20 kilograms maybe is for edema, because it's scrotal edema and the whole thigh is edematous and everywhere there is edema fluid. 20 or 25 kilograms may be edema itself. So I don't think it is correct for you
I
to say
agree, sir.
BMI.
Yes, sir.
I agree. I agree. I withdraw that statement. Okay,
I
next.
continue. Yes. So patient's pulse rate was 84 beats per minute. It was regular, low volume pulse with normal character, normal condition of the vessel wall, no radial or radiofemoral delay. All peripheral pulses were well palpable. Blood pressure was
Here,
9.
here I would like you to make a statement whether there is any evidence of pulsus paradoxus. because in between we have brought in constrictive pericarditis a possibility. So you should have made a positive statement that there is no pulsus paradoxus. How do you look for pulsus paradoxus?
Sir, we will actually tie the BP cuff around patient's arm. We will increase it
Yes,
to more
agreed,
than the
agreed,
60.
agreed. Yeah, it's mostly if you want to. The answer is it has to be done through the blood pressure recording. But of course, in patients with severe pulsus paradoxus, you can just palpate and find out. Okay, right. Go ahead.
Yes.
Total pulsus
Uh,
paradoxus in cardiac cabinet, it may disappear. Then there is no doubt. Okay, fine. BP is okay. Next slide.
yes.
It's
As
on
a
the lower
patient's
side.
respiratory rate is 28 cycles per minute, it's abdominal thoracic type of respiration. There is a use of accessory muscles of respiration. Saturation is 98% in all four limbs. JVP is elevated and pulsatile and is visible in sitting position up till the earlobe with prominent V waves.
What
Then
are the
steady
conditions
Now
state.
in the JV,
what are the conditions in which you can get prominent V waves in the jugular venous pulsation? Four
Sir,
or five conditions.
LV dysfunction can actually.
no,
LV dysfunction. LV
prominent
dysfunction
V
can give
wave.
prominent V waves
V
in
wave
LV
is a right
dysfunction.
heart problem.
Tricuspid regurgitation.
Yes, that's the
Yes.
commonest. Tricuspid regurgitation. Yes.
Great.
Other conditions.
RV failure.
Other conditions.
RV failure.
Then,
RV failure, the JVP can be elevated,
no.
but not prominent V wave. The mean elevation can happen. But tricuspid regurgitation, agreed. What else?
Right atrium is receiving a large volume and pressure from the ventricle. One is from right ventricle. The second should be from left ventricle.
How
Is
can
a
it
clue which we
left
can give.
going into the right atrium
Atrial septal defect
with
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 Pulmonary.
pulmonary hypertension.
MR. Okay.
MR? What
Then
else?
left ventricle directly to RA.
Sir,
We cannot give so many clues.
Yes,
Yeah, Gerbo deviation.
body defect, and also large volume of
RSV.
arterial blood coming to right atrium, rupture of sinus valve into right atrium,
RSV.
or a coronary cameral fistula draining, a large one draining into right atrium. So these are all conditions where there can be prominent V waves in the jugular venous pulsation. Okay, right? Yes.
In JVP, I'm not happy. You are saying that the JVP is elevated till the ear lobule. So you can't see
Yes,
the
sir.
upper layer. You have to say what is the A wave, V wave, and the descent. Descent is very important because we are discussing different diagnosis of right heart failure where constrictive pericarditis was discussed. So whatever the descents like, the Y descent is also extremely important. So JVP should be careful. Jugular venous pressure is elevated. It is up to the angle of mandible or to the air lobule. Sir, A and B we've seen. The V wave is prominent and Y descent is very important. What is the importance of that? When you get a prominent V wave, Y descent. Sharp Y
Rule out
descent.
constrictive pericarditis.
Sharp Y descent, severe TR, constrictive pericarditis. Slow Y descent.
Cardiac
Tricuspid
tampon.
stenosis. No, tricuspid stenosis. Tricuspid stenosis. Cardiac tamponade is different. So you should know
Absent.
the JVP of tricuspid regurgitation, various conditions which produce prominent A wave, absent A wave, prominent V wave, sharp X descent, sharp Y descent, A equals V. All those things you should learn because we don't have much time to teach all those things, but you should read.
Now, one thing, how can he has got a JVP elevated up to the ear lobule. How can you make out a prominent V wave? You can see pulsatile jugular venous pulsations, but you cannot make out a very prominent V wave once it is up to the, in sitting position, it is seen up to the ear lobule. It is impossible. And so,
Sir, is it possible that in the lateral expansion with a sharp Y descent, is it possible when you are looking at the lateral expansion with a sharp Y descent, which is most impressive?
If it is there, it can be definitely made out because there
You
will be
can say that. So only if that is there, otherwise it is difficult.
it is impossible.
Okay.
It is very difficult.
So
You
the,
should tell things which you cannot make out. And what happens in patients with what happens to a V wave in a patient with cardiac tamponade?
you should know these things.
You said about cardiac tamponade in prominent V wave. So what happens to a V wave in a patient with cardiac tamponade? Becomes more prominent, less prominent, disappear. It actually it becomes less and less prominent, and sometimes it may even totally disappear also. And so in a patient with cardiac tamponade, the VVA becomes less prominent. Okay.
Basically, cardiac tamponade is a unimodal ventricular filling, unimodal cardiac filling, so that you will get only the X descent. The V and Y will be very unimpressive. Okay.
But that does not mean that there is no filling of the ventricle. The filling definitely takes place, but the VA becomes less and less prominent.
Yeah.
That is because of the
Next.
ventricle becomes bigger and bigger. Intraperitoneal pressure goes up, and that is transmitted to the left ventricle, and that will result in a less prominent V wave. Okay. Yes. Go ahead.
Next slide.
Yes, sir. So cardiovascular system examination. On inspection, that trachea is central. Apex bit could not be visualized because patient was obese. Symmetrical bilateral equal chest wall movements. Dilated supraclavicular veins noted. There were no visible scars or epicardial supraclavicular pulsation. On palpation, inspectory findings were confirmed. Apical impetus was palpable in the sixth intercostal space, 1.5 centimeter lateral to the midclavicular line. It is diffuse, present over 2 to 3 intercostal spaces, and not well sustained, suggestive of hyperdynamic text beat. There was no significant parasternal heave, epigastric pulsations, and no palpable heart sounds.
Did you look for any pulsations in the third left intercostal space? And if you are looked for, what is the relevance?
Or the question will be, what are the pulsations you will look for? Which are the pulsations you can get over the precordium? One is LV apex. Second, you said RV. Something else?
And there are two more things. Of course, you can get sometimes arterial pulsations, but pulmonary artery and aorta also can be pulsations can be felt. But the cardiac chambers, two more pulsations.
In severe MR?
LA.
LA. The transmitted pulsations, so the LA can be felt over the precordium or the in the parasternal region, third and the fourth intercostal spaces on the left side you can palpate. And what is the other impulse which can be felt in the third left intercostal space? In Epstein's anomaly, you can palpate it. In RV endomyocardial fibrosis, you can palpate. RV outflow pulsations. RV outflow pulsations are felt. If you look at the pulsations on the right side, second intercostal space pulmonary artery, third intercostal space RV outflow, fourth and fifth intercostal space RV body. That's how it goes. And the transmitted pulsations from the left atrium also can be felt in the third and the fourth intercostal spaces, and very unlikely in the fifth intercostal space. Okay, yes, go ahead.
And descending thoracic aortic aneurysm can push the whole heart forward, producing a rocking movement in the whole precordium. That also can be, that will be very strong. Okay. Now here the problem is, when you are saying it is a hyperdynamic apex, that you should be careful because the pulse volume is low, the pulse pressure is low. So be careful. Be careful when you say hyperdynamic. You can say it is possible. That's enough. Okay, because that term will invite trouble. Okay, go ahead.
Yes. So on percussion, the left second intercostal space is dull to percuss. The right fifth intercostal space dull note to percuss, suggestive of the upper border of liver. The left-sided dull note is corresponding to the apex, and the right-sided is corresponding to the right sternal border. On auscultation, the S1 appears normal. There is a wide
Be very
variable
careful. Be very careful about S1 because we are not anticipating a normal S1. So be careful. Okay, go ahead.
That's a wide variable split.
Why we are not here? We are expecting a normal S1. What did Sudhemar say that?
Sir, there is a possibility of mitral regurgitation for which there should
And
be a
also, if
soft
the patient is
S.
in heart failure, especially if you are considering a possibility of dilated cardiomyopathy, that will result in a feeble S1.
Yes.
Okay, can you tell me? Okay, right, go ahead. We have to finish the case.
Here
Yes.
is a situation where the left ventricle is dilated and LV failure is there. So this one has to be soft. Okay, wide variable split FS2 with loud P2, LVS3 heard.
How do you
No
make out
murmurs,
whether?
no additions.
What is the criteria to say P2 is loud?
Sir, if P2 is heard from in any other space, any other location except the pulmonary area, it is said to be loud.
Yeah, if it is can be audible in the tricuspid area or it can be audible at the apex, you can consider that P2 is loud. Okay, any other?
In the pulmonary
So
area also
compared to
definitely.
aortic
Yes.
A2 sound, if
Yes.
it is
Compared
Yes.
to the A2 sound, what is the relationship? If the P2 is
if it is loud compared to A2 sound in aortic area, then
need not go
In
to
the
aortic
pulmonary area itself.
pulmonary itself. If the P2 is louder than A2, I think you have to consider that P2 is accentuated. Okay.
So
Yes.
if P2 is equal to A2 even. Because normally in the base, A2 is louder. Even though aorta is a posterior structure, A2 is better audible all over the chest, including the pulmonary area. So normally in the pulmonary area, even in the pulmonary area, P2 is soft compared to A2. Okay, fine, go ahead. No murmurs, no additional sounds. Other
If
systems?
you're asked a question about how to make out the loudness of a P2, you should say you have to compare with A2. And if it is even if it is equal to A2, I would consider that P2 is slightly louder in the pulmonary area. So even in the pulmonary area, normally A2 is louder than P2.
And
Okay.
if the split is audible over the apex beat, where the P2 can be easily audible, it has to be loud P2.
Yes.
In the normal split, the P2 will not be audible over the apex beat. So with
But
a split, if the
usually
P2 is
means
audible,
that usually means that the RV is forming the apex. Most of the times when you are hearing the P2 in the apex, usually the apex is formed by the right ventricle. So that is why the P2 is easily audible at the apex. Yes.
next slide.
sir,
Other systems okay?
No,
sir,
I
Any
think
proceed?
you just read.
the
Go back.
patient,
Go back. Go back.
sir, yes, sir.
S3.
No additional sound, no murmurs.
What are the reasons for a third heart sound? 3, 4 or 5 situations where you can hear a third heart sound.
Sir, sorry, LV dysfunction, we can have
Okay. 1, 2.
third,
Quick.
mitral regurgitation.
Yes, large volume coming in the rapid filling phase, mitral irritation, BST, PDA, all can give a third heart sound. Yes, what else?
What is the commonest?
It
With
can
normal left
be
ventricle.
physiological in some young adults and
Pardon?
children. Physiologically in young adults and
Yeah,
children, sometimes
physiological third sound
Yeah.
versus pathological. That's why you
Sometimes,
have to answer that.
sometimes up
Physiological
to
versus pathological.
yes, what else?
Okay.
Sometimes in patients with cardiac LV aneurysm, the aneurysm may behave like mitral regurgitation. During LV contraction, the blood can go to the aneurysm, and during the dilatation, it can come back to the left ventricle, and that can give rise to a third heart sound. So you should know the mechanisms of production of third heart sound. Yes, go ahead.
Don't say no evidence of any other heart sounds. Say no additional sounds, no murmurs.
Yes.
Everything, all the other things we have looked into. Other system, what specifically you look for in the abdomen?
Sir, we would want to look for any hepatomegaly, sir, to look for any
Okay, in the liver,
congestive
what will you look for?
hepatomegaly.
Very unlikely that no
Pul-
hepatosplenomegaly. What will you look for in the liver? Ankit
Pulsatile
also
liver
can
with
try.
Yeah.
What
tender
pulsation?
hepatomegaly.
Need not be there. In chronic heart failure, tender hepatomegaly is not seen. Tender hepatomegaly is seen when there is an acute congestion of the liver. Here it is chronic. So you may not get tender hepatomegaly, but what pulsation? Is it pre-systolic, systolic, or diastolic? Whatever it is. What is it? Yes, Ankit,
So
fully
systolic.
systolic because there is a prominent V wave in the neck. So there will be a prominent V wave in the hepatic vein. So systolic pulsation you have to look for. It will be there.
Yes,
And
therefore,
likely that
it cannot be certain that he has got a prominent V wave because the JVP is grossly elevated. So the
Yes.
liver, he has written there is no hepatosplenomegaly. A patient who has got a JVP up to the ear lobule, I would expect the liver to be enlarged.
that's what I said also. Sir, because he said there is a prominent V wave, the JVP is elevated. Most likely, if he's finding out U wave prominence is right, you look for that and say yes or no. Okay.
And what
Fine.
is the reason for patients to have tender hepatomegaly? What is the reason?
A capsule, the sudden expansion of the liver capsule.
It's an acute stretch. It's actually an acute stretch. It's an acute stretch of the Glissen's capsule, the capsule of the liver, which gives rise to tender hepatomegaly. So in a chronic congestive heart failure, the tender liver may not, the hepatomegaly will be there, but it may not be tender. Okay, yes.
Well, we go to the next thing because it's almost 9:30, sir.
Yes,
Now
yes.
8:30.
It's only 8:30. Yes. Okay, go ahead.
8:30. Okay, fine. Sorry.
Yes. Sir, this patient's ECG, sir. Patient is in sinus rhythm with
I
heart
think
rate of
Angit
around.
should discuss because Angit and Kuldeep discussed this ECG. I think, sir, I would like to see Dr. Ajay Mahajan after a long time. He is because very close as examiner.
Yes.
Nice to
I'm
see
there.
you.
I'm there.
Yeah, nice to
I'm
see
there.
you. Okay, fine.
Yes.
Okay, yes.
ECG taken in the normal standardization with the normal sinus rhythm, P wave followed by the QRS, and with normal P wave and normal PR interval, and normal QRS complex with
It's not normal
normal
QRS complex. So
narrow.
rhythm we have said.
In
Yes.
the limb leads, do you positive as normal QRS complex?
Sir, in the limb leads, short complex are there.
Yeah?
Low voltage
Low
complex.
voltage complex.
Yeah, it's
Low
low
voltage
voltage.
complex is there.
Define low voltage.
Why?
How to recognize the low voltage?
Less than 5 millimeter.
That's it.
in limb leads.
Hello,
What is the cause of low voltage in this case?
So it may be due to obesity,
Edema,
edema.
massive edema. Because
Yes.
there is one reason.
edema?
Because
So
there is a disparity between chest leads and limb leads. Okay. Chest leads abnormality in the QRS, normal or abnormal?
The poor RV progression is there.
Ankit,
Yes.
what is axis? You did not mention anything about
Yes.
axis.
Sir, no.
what is the QRS axis?
Left. Sir, left axis deviation is there.
No, there is no left axis deviation. What is the axis in this patient?
Which lead is equiphasic?
AV.
Look at lead 1, lead 2,
The
lead 3,
AVF is the one.
AVR,
AVF is
AVF.
the one. Equiphasic, and the axis
Yes.
should be around 0 degrees.
Yes.
So it
and the
does not
tallest QRS is in lead 1.
Okay. Does it help you in making a diagnosis? Is it that this patient is having ischemic heart disease, myocardial infarction?
What is the likely information you have? This ECG, among the different diagnoses we have discussed, is it a valvular lesion? Is it LV myocardial disease?
Do you think that this is amyloidosis? What are the ECG changes for amyloidosis?
Sir, amyloidosis, low voltage complex in presence of the LVH.
There will be low voltage complex in the limb leads. And what will be the abnormality in the chest leads?
Pseudo QS pattern in lead V1 and V2.
Yes, there will be QS pseudo-infarction pattern from V1 to V3. So if there is a Q pattern, QS pattern in V1 to V3 with low voltage complex and left axis deviation, that will be a point in favor of amyloid heart disease. So here,
Prolonged PR interval, disparity between the echo LV mass versus the QRS voltage. That is the way we suspect amyloid. Yes.
Okay.
So this favors valvular heart disease or a myocardial disease. Is it a right heart disease or a left heart disease? Overall, clinical as well as ECG.
and
Left heart
also
disease.
saying good, yes,
Myocardial.
you can
LV
see
myocardial
the,
disease.
Yes.
you can see the
Because there is a QRS abnormality.
Yes.
Loss of R wave from V1 to V3 and almost a Q there, and you have Q in 3 and AVF also. So there is extensive myocardial fibrosis. There is Q in lead 3 with all the reservations. Q in AVF, loss of R in V1, V2, V3, and V1 there is a very rudimentary Q R wave, a Q-like phenomenon and an R wave. And there is good LV forces on V5, V6. Okay, so
And
this is a LV myocardial disease.
and also there is a actually from V2 to V3 there is a dwarfing of the R wave. Whether it can be positional or not, that's a different question. But there is a dwarfing of the R wave from V2 to V3, which also is an abnormality which you can actually point out. Okay. Right, go ahead. We'll go to the exercise.
X-ray.
Yes. Sir, it's a chest X-ray, sir. Chest X-ray in PA view, and also chest X-ray in the lateral view, sir. Chest X-ray in PA view shows the trachea to be central. There is a cardiomegaly with
Now come to the important points. Your left border of the heart, any prominence? There is a cardiomegaly on visual assessment. And
Yes.
what about the left border of the heart? What are the structures from above downwards in the left border of the heart?
LV type of effects.
No, what are the structures in the left border of the heart from above downwards?
Sir, we will have aortic knuckle, sir. We will look
Yes.
at pulmonary
Yes.
vein. Then
Yes.
we
Yes.
will have left atrium, sir.
Okay, left atrial appendage, or sometimes RV outflow also come in that location, and then followed by mostly left ventricle. Okay. Any abnormality here?
What are the striking abnormalities in this X-ray? That's why I look into this case. What are the striking abnormalities?
Features of pulmonary
On
venous
anatomy, okay.
There is an effusion.
Physiologically,
pulmonary
is
venous
there
features.
pulmonary venous hypertension?
Yes, the features of pulmonary venous hypertension are there, sir.
Yes. Then
There is
what is
cephalization.
there on the right side?
What are the X-ray evidences of pulmonary venous hypertension?
There will be cephalization of
Yes, cephalization. Quick, one cephalization, two.
apex.
One is cephalization, two.
So two is there will be antlers.
Curly B lines.
Curly B line.
Curly V lines, yes, sir.
Then the third one, peribronchial cuffing. What is peribronchial cuffing?
We can see the edema, interstitial edema along the
Not interstitial edema. Edematous, the mucosa of the bronchus with a central black shadow, which is the air-filled shadow. So that is the peribronchial cuffing, the edema of the bronchus. What else? Ground
You
glass
can
appearance.
see that. You can see the cross section of the bronchi on the left heart. You have a dense small circle, and medial to that you can see two circles, and one circle is edematous. Okay, so that is very striking. Then what else?
And also you can have the ground glass appearance and pulmonary edema. So these are the five.
Curly lines you have to tell. Curly lines you have to tell. But what about the pleural effusion?
right
Is
side
there
is
pleural
the
effusion?
pleural.
So right side. What about this lateral view?
Yeah,
What
lateral
else
view.
apart from
What are you seeing there?
in the lateral view?
What is
What
that?
is that dense line you are seeing?
What is that fissure? What is that fissure?
Is it
What is that
horizontal or oblique? That line.
What
is
That is
that
oblique
fissure?
fissure.
What is that fissure which is filled with fluid?
Phantom tumor.
Not phantom tumor. This is the oblique fissure because it is going down. Horizontal fissure will be horizontal. Okay. Right side pleural effusion is more
Do not know. I
very
am not certain,
gross.
Sudhir, whether it is a horizontal fissure or I agree with
Okay,
you.
sir.
I am not certain.
Because on the right side, in the PA view, 1, 2, 3, 4, that level of that you are not seeing that horizontal thing in the PA view. First, second, third, fourth rib.
Because
We are
if
not
you look,
seeing that.
if
Here it is
you
quite thick. Anyway, it doesn't matter. You have to look
not
into
better,
horizontal
there
or
is
oblique
a
fissure.
yes, there is a phantom tumor or fissure fluid in the fissure, and also there is some amount of pleural fluid. That is definite. Okay.
Okay. So it's
uh,
consistent with your diagnosis of pulmonary venous hypertension and systemic venous hypertension, congestive heart failure with a left ventricular myocardial problem. That is very clear. Now we have to see what is the cause for this left ventricular
in this
problem.
patient with the left side disease, why the left atrium is left atrial appendage or left atrium is not enlarged? How do you make out in the X-ray test left atrial enlargement? What are the four features of left atrial enlargement?
There will be a double bubble sign which can be
Okay, you
seen.
can shadow through shadow. Yes, 2.
Yes, there will be straightening of the left heart
Don't
border
use
if
the
the
word
left is
straightening. The left atrial appendage
yes,
is prominent and is seen below the
from
coronary artery segment. Yes. Oh, third.
sir, on lateral X-ray we can
No, even the
there will be
X-ray chest
playing
lifting up
of
of
the
the bronchus,
pulmon.
lifting up of the bronchus, resulting in the carina becoming an obtuse angle, and 4. The left atrium can bulge beyond the right border of the heart. How do you make out whether it is the right atrium or the left atrium? When it is bulging beyond the right border of the heart. When it is bulging beyond the right border.
If it is occupying more than 3 intercostal spaces, it is probably right atrium.
No. You're
No.
not in the right track. So when you're sure, you can say, sir, I'm not sure. So we will teach you.
Yes.
Saves time. Okay. Well, many of the questions may be unfamiliar to you. Okay.
So in a patient with a left atrial enlargement, if it is bulging beyond the right border of the heart, you track the lower border of that shadow. If it is touching the diaphragm, that is more likely to be right atrium. If it is not touching the diaphragm, or if it is forming an acute angle with the diaphragm, that will be more in favor of the left atrium. Occasionally, you can see the left atrium bulging beyond the right border also. So these are the 4 features of left atrial enlargement in a PA view. 1, the double shadow. 2, left atrial appendage prominence. 3, lifting of the left bronchus. And 4, sometimes it can bulge beyond the right border of the heart. Okay, yes.
Echo. Shall we go to the echo, sir?
Yes. Echo and diagnosis, yes.
So, this is the this is a flat tube showing the aorta, left atrium, and the left ventricle. So, this is a short axis view showing the
No,
ejection.
don't jump to that. The previous one, don't jump to that. You have to say this is a parasternal long axis view. What is the left ventricle like? What is the left atrium like? What are the valves like? The left ventricle is dilated. Okay.
Yes.
What about its contraction? It seems to be hypocontracted. The left atrium is dilated. Mitral excursion is very less. The mitral valve is not opening well. That means the cardiac output or the flow is very low. The LV diastolic pressure is likely to be very high. The mitral valve is not opening well because of 2 things. One, the flow is less. Second, LV diastolic pressure is very high, so it prevents the full opening of the mitral valve. Then aortic valve also you can see what is the excursion to look at. You look at that aortic valve excursion. You can see what is the cardiac output like. Okay, next.
Is there any RWMA in this patient? Is the contraction all over the same, or do you think that there is a regional wall motion abnormality?
It looks like a global LV dysfunctions. As
I
such,
think
regional wall motion.
initially I had a doubt whether the posterior wall is contracting less than the anterior septum. So, but I think I agree with you that it is more of a global hypokinesia. Okay, go ahead.
I also thought like that. The posterior infraposterior region is not is much poorly contracting. Septum has
less.
some movement, but the problem there is a false tendon. That false tendon is creating an interference with the assessment of the motion. You can see that false tendon coming below that interventricular septum. Next slide. Next one. Yes.
This is
Oh, here
the
again.
short axis view, which is showing the ejection fraction of the left ventricle. So it shows that there is a global left ventricular dysfunction with the EF of around 25 to 30%. There is
So
no.
you say that the LV is dilated, LV is global. That also you have to say. And there is almost global hypokinesia, but there is some difference. It may be global because even dilated cardiomyopathy need not be uniform throughout. Because the fibrosis, inflammatory, what Dr. Tiny has discussed, the inflammatory markers affecting the myocardium need not be uniform. There is hypokinesia of all the areas, but I thought that, as Sir said, the inferior, posterior, lateral contraction is much less compared to the rest. But they agree.
I also feel that there is some degree of hypokinesia of the the posterior wall.
RCA territory.
Yeah, RC territory, RCA circumflex territory. There is some hypocontraction. We will see better in the two-chamber view.
Yeah. Next slide. Next.
Uh,
Yes.
this is the fourth chamber view, also, which is showing the left atrium, left ventricle, right atrium, right ventricle. At offset, there is the dilatation of left ventricle with the global LV dysfunction. The valve structurally appear normal, mitral valve appears
We
structurally
should
normal.
not talk about global hypokinesia in four-chamber view. So you are not getting all the coronary territories here. So that you should be careful. Only after looking into all the views, you can say that. In this, you will be asked which are the territories which you are seeing. So don't say global. You can see that these territories are hypocontractile. Okay, next. Next.
Yes.
What will be the
This is
question
a,
or issue here? There is mitral regurgitation. Your question will be, is it primary MR or secondary MR? What is the severity of MR? And you should be careful.
And
This
what
case,
is the mechanism? If it is secondary MR, what is the mechanism?
so it is a secondary MR, probably secondary to mitral annular dilatation because of
in this
LV
case,
dilatation.
I'm not sure it is mitral annular dilatation. You should know the mechanism of MR in secondary MR due to dilated cardiomyopathy versus ischemic heart disease. You should read that because we cannot teach everything because time doesn't permit us. So it's very important. You will get questions on MR, secondary MR, then transcatheter edge-to-edge repair. What is its role in secondary MR? Evaluation of secondary MR in this case. We have to assess how much the MR is contributing. So don't be very casual. Though it doesn't look severe, you should be careful. Assessment of severity of MR, primary and secondary, the criteria is almost the same. Criteria is almost the same. Okay.
In secondary MR, in a patient with dilated cardiomyopathy, when does there is a regurgitation? Is it early regurgitation, mid, late, or pan? When does the mitral regurgitation occur in patients with dilated cardiomyopathy? It's an early regurgitation. While in ischemic cardiomyopathy, it can be early, mid, late, or pan. But usually in dilated cardiomyopathy, it is actually an early mitral regurgitation. And as the contraction progresses, the mitral regurgitation disappears. That is because it is mostly related to size of the left ventricle, where the papillary muscles pull the leaflets in a wrong direction, resulting in early lack of coaptation, resulting in early mitral regurgitation. And as the ventricle becomes smaller and smaller, the mitral regurgitation disappears. But in ischemic cardiomyopathy, it can be any, where it depends upon the ischemia at the papillary muscle. It can be early, late, or even pan.
Because in ischemic heart disease, it's a ventricular dysfunction. Sorry, in dilated cardiomyopathy.
Yes.
Whereas in ischemic heart disease, there is some mechanical contribution also, papillary muscle also. Second thing, why it is early in dilated cardiomyopathy is, what is the LA pressure? The MR occurs from LV to LA. So the LV to LA pressure gradient is the important thing. LV is not generating pressure, but the LA pressure is high. Let us say the onset of systole, LA pressure may be 25. And when it receives MR, the LA pressure progressively rises so that the LV to LA gradient comes down in the latter part of systole. I don't know whether it is clear or not. That is, the LA pressure is high in this case.
And also, Sudhama, there can be, yes.
When the ventricle starts contracting, it empties the volume to the LA, so the LA pressure rises. LV pressure cannot rise because it is severely dysfunctioning. So the LV-LA gradient comes out in the latter part of systole. So the mitral regurgitation need not be pansystolic.
And also, because of the ventricular size, actually it is significantly big, because of which the coaptation does not take place. And as the ventricle empties its contents into the aorta, the LV size comes down, and then the coaptation becomes much better. And so late there is a good coaptation of the mitral leaflets, while in the early part there may not be that much coaptation, so there can be an early mitral regurgitation which may disappear towards the later phase.
Okay, next.
Okay,
What you
next.
want to know is the left
What about
ventricle to be
what
assessed
about
in
the right
different ways.
ventricle? What about the right ventricle?
That's it. Right ventricle, TR jet gradient. Yes.
Right ventricle
Okay.
dysfunction, sir. TAPS is 1.35 centimeters, sir, which is
Okay.
suggestive of RV dysfunction, sir.
Okay.
So there is a biventricular
Okay.
dysfunction. Yes,
I
okay.
Yes,
know,
sir.
but I want the pulmonary artery pressure. Right ventricular dimension, right atrial dimension, the pulmonary artery pressure. That you should have that. Then TAPSE alone is not enough. You should read RV function evaluation by the simple echo, tissue velocity Doppler, and CMR. So you should read about RV function because now things today we are taking this a teaching session, but in the examination it will be a targeted thing. We will not take this much of time. We'll ask random questions and we'll bring you to RV function evaluation. The simple transthoracic echocardiogram, then strain rate, the right ventricle, global strain, all those things, then cardiac MRI for RV function assessment. So you should read that. Okay.
Now,
Next.
doctor, what are the if you want to look at serially RV function, what is the process by which you do that?
Sir,
RV function.
we will look for TAPSE, sir. We will look for R. So we will look for tricuspid annular pulmonary systolic excursion more than 24 plus or
No,
minus.
first thing that you should look at is the comparison of the size between the left ventricle and the right ventricle. The right ventricle, when they develop dysfunction, they progressively dilate in size. They become bigger and bigger. What is the normal relationship of the left ventricle and the right ventricle in a normal person in the apical four-chamber view? The right ventricle is two-thirds the size of the left ventricle. If the right ventricle progressively dilates, that obviously means there are two things. One, the patient has developed RV dysfunction, or two, the patient might have developed RV must be functioning well, but might have developed a volume overload and dilatation of the right ventricle, as can occur in a patient with ASD. And this can be differentiated by making up doing the TAPSE. If the TAPSE is normal in a dilated RV, it obviously means the RV is dilated because of the volume overload. If the RV is dilated because of the poor functioning of the RV, TAPSE will be reduced below less than 1.7 centimeters or 17 millimeters. Okay. Then second point is if you want to do one more step and to assess the RV function, what is the parameter that we will look for?
RVS primes.
Hmm?
RVS prime. We will look for.
RV?
S prime.
RVS prime.
Yes.
I would like to look at fractional area change, FAC. The fractional area change of the RV is supposed to be one of the very easy and one measurement that you can do without much difficulty. And what is the normal fractional area change?
35%.
Yeah,
More than 35%.
More than 35, usually it is near about 45. When it
Yes.
goes below 35, that means there is RV dysfunction. So
Yes.
even by looking at the apical four-chamber view, you will get an idea whether there is an RV dysfunction. If the RV is two-thirds the size of the LV and LV is near normal and RV is two-thirds the size of the LV, most likely RV function is normal. Okay, right, yes. Go ahead.
Yes. So we have done an angio of this patient.
You're not mentioned about the size of the the pulmonary artery pressure is very important. Looking at the tricuspid regurgitation and looking at the right ventricular pressure, pulmonary artery pressure.
Sir, it's not come in the PPT, sir, but the pulmonary artery systolic pressure by tricuspid valve jet was 64 mmHg, sir.
64. Oh, that means there is a.
Yes, sir.
Is it after adding the RA pressure or without that?
Yes, after adding the RA pressure, yes, sir.
How much did
For
you add?
dilated IVC.
How much did
Sir,
you add?
since IVC was dilated, I have added 15, sir.
So you added 15. Okay, right. Okay. So adding 15, it is about 64. So all right. Okay. Yes. Go
Yes.
ahead. Go ahead.
Sir, even GLS of this. Yes, sir.
Timer has appeared.
Yes, sir.
Dr. Arun has appeared.
Okay.
Morning.
Okay. Just one
Yes.
more thing only.
So
Then
what
we
is your diagnosis now? What is your diagnosis now? If you're
Sir,
asked anything, we will not give you the yes. Sir,
sir,
it
the
is
diagnosis is congestive
chronic
cardiac
congestive
failure
heart failure due to left
with
ventricular myocardial
dilated
dysfunction,
cardiomyopathy.
likely to be dilated bar ischemic cardiomyopathy. Mitral regurgitation severity you have to assess. Pulmonary arterial hypertension, tricuspid regurgitation, congestive heart failure,
no,
sinus rhythm,
they were tricuspid
NYHA3.
regurgitation based on what? V wave?
Because he has a prominent V wave and he has picked up a. No, I was just putting the whole thing with all the limitations in his presentation.
There is no parasternal lift. There is no murmur. Nothing. So you
Yeah,
cannot
agreed, sir.
diagnose
Agreed, sir. We may
tricuspid
have to
regurgitation.
auscultate again. We have
Yeah.
to examine again because his
Then
pulmonary artery pressure is 65. JVP is up to the angle of mandible and he said a prominent V wave. So I think
and
there is some incongruous data.
he categorically said that there is no parasternal lift.
I agree. But that will be my final diagnosis based on the data available. Okay. So you
Okay.
go for angiogram. Yes.
So this is the caudal view angiogram of the left system. So it cannulated via the Judkin's left catheter. It shows significant left main disease with maximum
No,
disease at the
basically,
shaft.
as a postgraduate, it's a part of teaching, not criticizing the person who has done. The catheter has not fully engaged the LMC. So that's a thing which you should learn. Not we are not interested. When you are going to do the angiogram, you should know all the finer details. We are not criticizing the consultant or the resident who has done it. You should not do like this. So that's the first thing. Is it a properly done angiogram? So the catheter is not engaging the LMCA, so that you are not getting a good picture. Am I right, sir?
Yes, not engaged and also not well aligned also. So that
Yeah.
the engagement of the catheter is not perfect.
I was going more into the iota. Okay, fine. So before interpreting the data, it should be a properly taken angiogram. That's a lesson which we want to tell you when you are going to practice after your course. Okay, fine. With due respect to, and we are not criticizing the person who has done it. Yes.
Sometimes even if after the best attempt, a good engagement or good a good catheter engagement may be difficult. So we know that there can be limitations, but you should give a comment that this is not a where the catheter is not well engaged into the coronary artery. Yes.
So before attempting to read, sir, there are lesions, multiple lesions, and I would like to have the other views also. Because here the dye is not proper. Okay. But you have some information which I would like to discuss after saying, because you are postgraduates, not consultants. So you should go to the next frame and get full information. You should not make decision based on a single frame. Okay.
Our
Next.
impression that the posterior wall is hypokinetic
Yeah,
and
that's right.
well supported by the severe narrowing of the major OM.
That support the statistics also. 60-year-old diabetic patient with a left ventricular failure, ischemic should come first. Then only comes other myocardial dysfunction. Okay. Next test frame, next sequence.
And more important is that when it is ischemia, some treatment is available. And always when you are in difficulty, always go for a condition where a treatment is available.
Okay, go ahead. Next. Okay.
This is a PA view, sir, which is again showing calcific.
He has got multiple narrowings. The left main, LAD.
Left main, LAD, bad disease.
Everywhere there is
The,
lesions.
the diagnosis is there, but
Yeah.
importance is regarding management. That is the issue here because we know it is severe coronary heart disease, ischemic heart disease. Our aim is whether you will go for revascularization. So that should be the approach in this case. I think that
And
you should learn from
if
consultants
you have to
now.
go for revascularization, what is the best revascularization for this patient?
Sir, he would be better benefited by coronary artery bypass grafting, sir.
Okay. Okay. There be controversy on that thing. You need not bother about the decision now at your level. This, I will discuss with my senior consultants because it's a high risk case. The vessels are not good. Very extensive disease in a diabetic. The target vessels are not good. So I'm not competent to make decision. The surgery has its limitations. So I will discuss with my senior consultant or the heart team. Then only decide. That is what you have to tell. That is what is
Because,
needed also. The heart team
because
in
of
these
the
types of cases.
patient is in severe heart failure, he has got a left main disease, multiple triple vessel disease. What would be the syntax score in this patient? Did you calculate the syntax score?
It would be more than 34, sir.
More than 34. Yes. What is the how do you how can this index score help you to take a decision?
Sir, as per 2020 index score, so if it is more than 34, it tends to be better. The CABG tends to be a better option.
Yes, if it is less than index score less than 22, these patients are candidates for angioplasty. If it is more than 33, these are patients are candidates for CABG. And 22 to 33 depends upon the person who is taking the decision. It can go in either direction. So this patient index score is more than 33. So most likely the patient will benefit by a CABG.
Other views, because I am not happy with the circumflex, I may differ. Okay. Ejection fraction, how much?
Sir,
26.
25%. Yes.
25. Okay. The other views?
Did you do an LV angiogram in this patient?
No, sir, I'm not an LV angiogram.
Hmm?
No, sir, LV
Will you try?
angiogram.
Will you try?
No, sir.
What additional information you are going to get? And the risk of pulmonedema is very high.
Yes.
So unless you are going to get good information, because LV you got good idea. MR assessment by LV angiogram in secondary MR, it is quite difficult. That
And
is, you
also
underassess the severity.
already ECHO has given you most of the information that is required. So creating a complication may not be the correct thing to do. So I think the additional LV angiogram is not indicated. The patient can, why do the patients with LV angiogram may go in for pulmonary edema? Sudhemar said they can go in for pulmonary edema. What is the reason? What is the reason? There are two reasons. One, contrast media can depress the myocardium and that can result in further elevation of the left ventricular end-diastolic pressure. Two, contrast medium is hygroscopic and that can increase the volume and that can also give rise to pulmonary edema because you are injecting a large volume of blood, large volume of dye quickly into the left ventricle. So that can give rise to.
You are giving it acute volume overload.
So that can give rise to pulmonary edema. Okay, yes.
And they will develop ventricular arrhythmias, they will develop pulmonary edema. So there is no need for angiogram. Right coronary? Any angio?
Yes, sir.
The last one which I saw was not okay.
The right coronary seems to have an
It's a
anomalous
diffuse
origin.
disease.
Yes.
What we want to know is the target vessel. When you are giving this case for surgeon or discussing with the surgeon will be looking which are the target vessels he can tackle. That is what we have to find out. There can be differences of opinion among the doctors, but overall, what do you feel in this case? Management, optimal medical management with all the things. Will you go for revasc?
If I am to give my opinion,
will.
I will definitely go for revascularization, and my approach will be CABG because he has got extensive disease, and CABG can surgeons can do a endarterectomy, and they may be able to put the graft, and if there is a effective flow through the graft vessel, the patient has got a good possibility of survival. But regarding angioplasty, he has got calcification, extensive disease, left main disease. So I would not consider the PTCA as the first possibility. even though you may have.
I will go for
gadget.
optimal medical treatment, sir, because to me, the target vessels, I'm not comfortable, but I am not the person to decide. So we discussed with the team, with the surgical team also, whether they are comfortable to do the thing, because the operative risk is very high.
That is there.
Post-operatively, we don't know.
That is
So
right.
there
Because of
comes
the,
whether what is the ischemic pattern here. So in such situations, how much is the ischemic burden? I don't know whether we should go for assessment of the viability of the myocardium, the perfusion of the myocardium. So the viability of the myocardium to be studied to see whether by improving the perfusion, then what is the perfusion status? These things to be assessed in this case before considering a revascularization, but it is a team decision. Then surgeon's role is great in this case because they should be comfortable because the operative risk is very high. And surgeons, ordinary surgeons do not want to have a bad outcome following surgery. So our approach depends on where you are working. Where I am working, our surgeon may not be keen to operate on this case. But if you are going to operate on this case, we should make sure that the myocardium there. So, for example, if you are going to revascularize LAD, RC, I'm not sure, circumflex, I'm not sure whether there is perfusion defect and what is the viability. These things to be studied, and that study itself carries a high risk by nuclear imaging or cardiac MRI.
if you are to do viability test, what will be the preferred viability assessment in this patient?
Sir, stress myocardial perfusion image. The rest
Do you,
and stress
do
myocardial
you,
perfusion.
do you think that you would like to do deputy minister's echo? And if it is a deputy minister's echo, what is the pattern that you expect in this patient, which will prove that the myocardium is viable?
So if you do a dobutamine stress echo, if the myocardium is viable at low dose dobutamine, the uh,
What is the name of
contracting.
the seen a patient who has got severe LV dysfunction, where you think it is hibernating myocardium? And if dobutamine stress echo is done, and what is the response which will tell you that it is definitely viable? What is the name of that response?
Biphasic.
Yeah, biphasic response. Where initially with a low dose dopamine, there came an improvement in contraction, and that is immediately followed by a more severe LV dysfunction. A biphasic response will definitely tell you that myocardium is viable, and these are candidates who can be reperfused, or these patients can be revascularized. Okay, I think Sudhimar, we had most
I
of the
think we
points.
had a good discussion,
Yes, yes. I
good
think this
interaction,
good
good
case also.
teaching,
Good case also.
reasonable answering,
Yes.
and
I
more
think
important, sir, there was a lot of chats. Chats, there was 100 plus, and some of them were excellent answers. Some
yes.
of them were not that good, but there was a very active interaction from the audience. They were asking so many answers they were putting. Majority of the answers they were putting were right.
Right
A
also.
few,
Yes. I also
obviously,
I
I,
noticed
I was
also.
going through that. I was going through that.
I also went
Those are
through that
good
and I
answers.
found that somebody has
Yeah,
suggested MRI. That's what I want
ah,
to ask him.
all right.
That MRI, I do
So
not
I,
know whether it is a right choice or not, because either the vitamin stress echo or the patients can undergo stress thallium or stress system maybe would be the correct choice to assess the myocardial viability.
I think we should appreciate the audience participants also for their active participation and reasonably good performance from both the discussant and the presenter.
And I think we
Dr.
could
Ajay, nice to
finish on
see
time.
you.
I think Arun will be happy that we could finish almost on time.
Yeah, we have had a wonderful case, and I must admit that there was both the students and the teams did well. The presenter also did well, and the student also did well. And I hope all of you have learned how the examiners took you through this case. Uh, Essentially, it was more the examiner speaking rather than the student speaking. So teaching each and every nook and corner of the whole session. So I think. And that probably reflected the way the students and the delegates answered as well. So I think hats off to all the those the delegates who have attended. So thank you all. I must thank Ajay Magan sir and his team for bringing up this case, and Surinder Diora sir and the team from AIMS as well. And the examiners, Sudhima sir and Manjuran sir, for the excellent discussion. We had an excellent talk by Dr. Tiny Nair sir on beta blockers in HFPEF. I hope all of you listened, and don't be surprised if you get this for an exam as well. It's an important emerging topic coming up. So um, I thank all the everyone who has worked behind the Heart Failure Association of India. In fact, we have the Heart Failure Association of India brainstorming session going on because the association is going into greater heights now. We've been collaborating with the Heart Failure Society of America and other international societies, and we'll have talks from foreign faculty as well, every organization. So we'll come back to the next session as well. Must place on record the work done by Chopra sir, Dr. Abraham, and Dr. Harishan, Dr. Sajan, and entire team who has worked behind HFAI. We got an unconditional support from the pharma to the Corona Solution of Sun Pharma, the Vinay and the Netcast team, Sumita and everybody. Thank you for working on this and having this platform becoming an important international academic event. We'll get back next month on the second Saturday with two teams. KM continues in the student panel, and Negram Shillong will be in the presenting team. So thank you. Sorry for keeping you late, but I hope it was as I've enjoyed. I hope all of you have enjoyed as we see in the webinar chat box. Keep learning. Thank you all. Good night.
Thank you, Arun. Thank you, Arun, for
Thank you, sir.
discussing this the whole process, and it was a wonderful case to discuss, both for students as well as for examiners. And I think students did reasonably well. I won't say that exceptionally well, but reasonably well. Okay.
Thank you.
Okay, thank you. Good night.
Thank you.
Good night.
Thank you. Good night.
Good night, sir.